Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good afternoon and welcome to Filibuster and Fine Print, AMGA's public policy podcast. I'm Chet Speed, your host, with a all-star team. It's the same team, actually, as always.
Minus one.
Minus one. Ooh, you're right. Yeah. We miss you, Jamie. We miss you.
And then we laugh.
No, we don't. No, we do.
Jamie, we'll see you next week. We've missed you very, very much. Anyway, so let's introduce the team that is here. And then I have a question for everybody. And then we're going to talk about a CMMI model. So that'll be exciting.
I'm excited.
Dale's excited. He's got his black horn glasses going, so he's looking very reg. All right. Well, can we start?
Alicia Sawyer, Government Relations Assistant.
Lauren Latney, Director of Government Relations / Taylor Swift Wedding Planner.
Oh, yeah. Sounds a big deal.
We should just talk about that.
We'll see. Mm-hmm. I probably have to sign an NDA.
What's that?
I'll probably have several of them, probably.
Yeah, and naturally.
Yeah.
Hi, everybody. Daryl Drevna, Senior Director of Regulatory Affairs.
Right. And welcome back. We've been gone for, I think, 2 months. And hopefully we might not be quite as smooth as we typically are, but give us some time. But we're excited to be here. So question of the day is, how did you all spend your summers?
Oh, everyone's looking at me. I guess I'm going first.
Yeah, you're going first.
I was just thinking, I was like, what did I do this summer? I spent some time in Oregon. I went backpack camping for the first time. I spent some time in Denver. Had a very outdoorsy summer. Lots of time touching grass. I think that was very needed after OBBA. Some time outside, some fresh air, and ready to get back at it now.
Good. We'll hold you to it.
Mine is morbid. I kind of don't want to share it.
Oh.
Yeah, because the first thing that came to mind is I went to a bunch of funerals this summer.
Did you really?
I did, at least 4.
And you did.
Yeah.
Both of you went to my mother's.
Which was a lovely service.
Well, good.
Yeah.
Thank you for coming.
The church looked like a British mystery church, which started, I was watching Fool's War, started Shetland. So it was very inspirational in terms of my television watching.
Oh, good.
Yeah.
Well, we aim to please.
I drove up and down 95. I went north to New York for a college reunion. Then I drove south to Orlando with a stop at Myrtle Beach and then back. So, yeah, we were all over the place. And then I spent a week at Boy Scout camp. So it was a busy summer.
Wow. Okay. Yeah. So we have 2 outdoors and 1 morbid.
Yeah.
Very good. All right.
Switching it up.
Yeah.
What'd you do this summer?
What did I do? Let's see. Well, so the biggest thing was Barkley, my daughter, and I played in the same lacrosse tournament in Lake Placid. So she played the first 3 days, and I played the second 3 days. And there's a picture of us, both in our uniforms, at Lake Placid.
He's beaming right now.
I know.
He has no idea.
I can see his face.
The glow.
Yes.
Happier to have played in the same tournament as my daughter. So
classic girl dad.
Yeah, and she did note that she was much faster and much more talented than me or any of my teammates, which is all true. But
you got to keep it real sometimes.
Oh, she keeps it real.
Right. Mm-hmm. Yeah, it comes directly from God to their lives. There's no filter.
That is from the lips of babes. Right. So that was good. Thanks for asking. It's good. So let's see. Speaking of morbid, we're going to talk about a CMMI model. It is called the WISeR model, which stands for Wasteful and Inappropriate Service Reduction Model. I must admit, I'm going to show my age. Every time I hear the term WISeR, I think of that Budweiser commercial.
Laura and I were talking about that earlier this morning.
WISeR.
Right, the totes.
Mm-hmm. Yeah. I don't think they'll appreciate that, but it is what it is. So a lot of time you can spend on this. What exactly is the WISeR model? What does it intend to do? What's the reason for it? And all host of questions around this model, because it could have a big impact on AMGA members.
Yeah, that's a lot of questions. I will answer
You're
them.
welcome. Yeah, sure.
And how WISeR will work is It's a pilot program that will be implemented in 6 states: New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington, for a period of 6 years starting on January 1st of 2026 and ending December 31st, 2031. And WISeR will require prior authorization for 17 kinds of services that CMS believes are either commonly overused or historically have had a higher risk of waste, fraud, and abuse. These services include skin and tissue substitutes, electrical nerve stimulator implants, and knee arthroscopy for knee osteoarthritis, some spinal procedures like cervical infusions and epidural steroid injections. And so they are targeting these for their believed limited clinical benefit and high risk of waste. And so the WISeR model will leverage AI and machine learning in the review process, but will still require the utilization of clinicians in review processes. And with all of that, I think it's important to note what WISeR is not. It does not change Medicare coverage policy, and it does not restrict patient choice.
So they say.
I think that's a long way of saying it's a bounty program. Like, they are going to have contractors taking a look at these services, and if for every the amount of savings they generate by either denying claims or refusing to pay claims or denying services, they'll get a cut. So.
That sounds like a bounty to me. So CMS under CMMI is for the first time creating a prior auth program within traditional Medicare. Which is interesting because when Dr. Oz was going through his testimony before he became administrator, he talked about the need to limit prior auth.
Very vocally. Like, he went a whole rant on it.
Mm-hmm.
He called it a pox on the system.
He did. And so the first thing out of the gate is a prior auth system.
Well, I guess how pox can spread.
Right. Well,
we heard that in 2020.
Right. Yeah.
Interesting. So I did talk to Jerry about this, Jerry, our CEO, and he had made a good point. Dr. Oz is he's acting like he runs an insurance company, which is what Medicare is. It's probably the largest insurance company in the world, and that's what insurance companies do. They do prior auth. So interesting.
This also feels like they're doubling down on a bad idea. And we're going to talk about this a little further when we talk about what's going on the Hill about this. But it really is, wow, traditional Medicare as we know it may change. This is a volunteer model, but I'm nervous.
Yeah, I think they're trying to, I think if you ask CMS, like, what are you doing this? Well, we're trying to level the playing field by extending prior auth. They're trying to make this, we're going to simplify this because it's, now we've got this uniform framework across the programs. But I think if you're sitting in the provider chair, like, this doesn't add up at all. All of a sudden, you're imposing these new requirements, and you've sort of contracted out this opportunity for private contractors to, deny claims and make bank on it.
Mm-hmm.
If we can say that, is that still a thing? I don't know if people say that.
We're gonna. What? We need.
Yeah, you can say that.
Okay,
that's okay.
Yeah,
that's okay.
Yeah.
I thought, wow.
But it's also this implementation of AI also into the Medicare system at a much higher clip, I think. The White House has been working with CMS on this. They had a healthcare ecosystem tech event at the end of July that was talking about how do we bring more tech into CMS? How do we bring more AI into CMS? It was a huge rollout. I think there were very few. There were a lot of tech companies. OpenAI was there, Microsoft, Facebook maybe, but there are not a lot of hospital systems. There were not integrated systems. There weren't a lot of provider groups there. So it seems like they're going their own way without bringing sort of buy-in from the medical community, which is a interesting way of doing things. I was on a meeting with some CMS and CMMI people who do these projects, and they basically said the WISeR model is what they think prior authorization should look like in the future. So they are all in on this.
Yeah, they see it just right in the name, wasteful, inappropriate services.
Mm-hmm.
And these are services they're saying these are low value or they don't have a clinical benefit. And, you can argue that, but you've already put these services through the NCD process, through the LCD process. So they're vetted and approved before, and now we're going back and saying we don't see the value in these, so you're going to have to really justify when you order or prescribe these services.
So relatedly, so how will this work for providers?
There's a couple different ways that this is going to work. It's really a three-pronged. Ultimately, there's three ways. Either the provider is going to submit a prior auth request directly to like the WISeR, what they're calling the WISeR participant, and this would be that that contractor. So you put your request in directly to the WISeR contractor, or you submit your prior auth request to your existing MAC, your contractor, who then turns around and routes it over to that WISeR contractor, or the third option here is you just go ahead and do the service without requesting prior auth, and then that WISeR contractor potentially could flag it, and maybe the claim could be denied prepayment for medical review. So either there's three choices here. One, you put it to the WISeR contractor. Two, you submit it to the MAC and they kick it over to the WISeR contractor.
So secondary bureaucracy.
Yeah.
Okay.
Or three, you're like, YOLO, we're gonna do this and see what happens, and then maybe it gets denied, maybe it gets claimed, and the WISeR contractor will get back to you.
Man versus machine. That's immediately what I thought. It's like you're competing against AI, which has already been used in Medicare Advantage and already controversial. Now they're like, oh, let's just make it fun for everyone.
Yeah. Well, I guess it does equalize Medicare Advantage and traditional Medicare. And it does feel like in the traditional Medicare setting, fee for service, all the risk is on the provider. So they're going to have to hire the people to sort of go over the claims, do the prior auth processes, et cetera, without any benefit whatsoever. And I never had to do this before in the first place. By the way, I had epidural injections in my spine, and frankly, they saved me. So there wasn't low value to me. Okay. I don't know. No one cares. So
we'll put that in our comment letter.
Well, my mom actually had the nerve stimulator in her back, and it was very helpful to her. So you got two people on here, personal testimonies. That's 100%. Data. Right.
We're almost statistically valid.
Right.
Sample size of 2.
Yeah.
We're go with that.
So we touched upon it a little bit earlier, but let's be a little more focused on this. Why is CMS doing this?
CMS is looking to reduce the volume of low-value services furnished to original Medicare beneficiaries, and that's really just to reduce cost in Medicare fee-for-service.
Okay. Yeah. And we talked about this also. So this is different from what Dr. Oz said earlier.
It is. It is. I mean, he, and Lauren mentioned this at that hearing, he's, has framed prior authorization as a barrier to care. But now they're saying well, this isn't changing coverage or creating new barriers. They're calling it or characterizing it, it's a review support tool. And this is a way to add, this is all about accuracy and consistency, not limiting care. So they're putting a spin on it that it's not really a prior authorization program, but we're just ensuring that these services are medically appropriate, which I would argue is prior authorization.
Yeah, I sort of agree.
Yeah.
So what is the congressional and also the stakeholder response to this new model?
It's not great. Mm-hmm. Congress has been doing this a very long-term conversation about prior authorization. Mm-hmm. It's bipartisan. There's so many bills and letters to CMS that have been talking about this for years. I mean, this is an established template. This is one of the few things that Congress agrees on. And so, this was introduced this month, and it's still kind of rolling through in terms of what the overall congressional response will be, but it's not going to be great. There's already something that's already floating around, right, Alicia?
Yeah. Susan Del Bene of Washington, Amy Barra of California led a group of 17 House Democrats in raising concerns about this program, this model, and how adding new red tape to traditional Medicare will delay and worsen health outcomes. prior authorization in MA already delays and denies care is what they're saying. And the question is, why add the process to traditional Medicare after publicly acknowledging the harm it causes? And Del Bene has also done some work on prior authorization in MA, introducing a bill in May on MA.
Yeah,
PA.
and has a history of this, right? Yeah, she has the Senior Timely Access to Care Act. I mean, if you want to be an important member of Congress, you need a big bill, and you need a big bill with a lot of members of Congress signing on to it. This is a big bill. This is something that has not only been going through Congress, it's passed out of the House. But it was a cost factor to it. It was really, really expensive. But then the Biden administration sort of implemented a lot of the things that were in this bill through their regulatory process when he was over the administration. So it seems like we're taking not only a step back a little bit in what was congressional intent, what was previous presidential intent, and also adding like so many other layers of bureaucracy. This is not small government. This is big government, big contractors, and a lot of could be instability in a healthcare system that's already going to be facing cuts in Medicare and already facing cuts in Medicaid, and now being asked to do all of these additional red tape issues.
Yeah, it does seem like this is a very, like I said, a tough road for the doctors whose Part B reimbursements have been declining over the past several years, and now you're adding a prior auth mechanism to traditional Medicare.
Yeah.
Is there any people that support this thing?
Yes, like the Paragon Institute are they're out very much in favor of it, and they it's right in the name. They are very upfront about the fact that they believe Medicare is spending too much, and they're looking for CMS generally is spending too much, and they are looking for any avenue they can to reduce spending. And this is just another example of that. So if it works from their perspective, and either it changes provider habits and prescribing patterns, so they stop using these services, so they don't even go through pay premium, that would be a win for them, because all of a sudden you're not billing for that, or these claims are denied. So eventually they're trying to force the issue, and it's sort of a backdoor coverage change.
Paragon is powerful. I mean, they're a relatively young think tank compared to something like the Heritage Foundation or Cato Institute, but they are very powerful. They have their alumni are all over the Hill. They're all over CMS. And every day they're sending out emails about what they feel policy should be, and very much trying to deny what providers and members of the healthcare stakeholder community are saying is going to potentially happen. They are good at rewriting narratives. They are very influential in this administration and on the Hill. And so whatever happens, I would look to Paragon first.
That, and of course the tech companies, right?
Yeah.
There's a new potential new player in industry. I know tech's been really interested in trying to get into this space, and this is another opportunity for them to do so.
Absolutely. So, and then I should know this, but I don't. When does this start? Are they taking comment?
So on your second point, no, they're not taking comment. Okay. This did not go through. I get really agitated. Sorry, it's like they are not taking comment.
So bad.
So here's this quote unquote voluntary program that is voluntary in name only, and they completely circumvented the formal rulemaking process. So there was no opportunity for public input or reviews or changes to the program. Alicia, do you recall when it starts?
Yeah, it starts January 1st, 2026.
Happy New Year.
Okay. All right. That's
yeah,
soon.
a lot of things happening at the beginning of next year.
Okay. Well, that's great. And any other comments on WISeR or summer breaks, or Mike, anything from you?
Same old.
He says same old.
Same old.
Yeah.
Same old best producer in the world.
In the world.
No,
at least in this room. You're welcome.
I would just say I would expect this is not going to change. So to Elise's point, this starts at the beginning of the new year, and get ready, because I would expect this to get implemented as proposed. I don't see them backing off from this.
Okay. We will leave the last word with Mr. Drebna. And that's it. Thank you all for listening, and have a good rest of the day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.